Presentation today. I'll be covering mental health conditions. Like I stated, my specialty is obstetrics and gynecology. Granted, I'm in my second year of training, but I can kind of speak with what I've experienced so far, especially given the high patient volume and our wonderful Promise to Hope program that we have over at Miami Valley. Okay, so in terms of disclosures and housekeeping, the viewpoints that I am expressing here are for educational purposes and not a reflection of the U.S. Air Force, um, Wright State University, or other associated affiliations. I am the current resident fellow chair for the Ohio State Medical Association, so I do work in conjunction with them, as well as our delegation to the American Medical Association. I do not have any financial disclosures outside of that. In terms of agenda for today, we'll cover a brief background as to mental health conditions that do exist within pregnancy and how it affects risk factors. We'll also go over some screening tools that we do utilize, especially in my own practice, major diagnoses and common diagnoses, as well as treatment and management inclusive of pharmacotherapy. So in terms of our learning objectives, what I'd really like for us to do is conceptualize mental health conditions that are common in perinatal and postpartum periods, synthesize screening methods and risk factors for vulnerable populations that we can focus our attention on and target, as well as discuss modalities and clinical toolkits that are appropriate for longitudinal treatment. So let's jump right into it. I by no means can describe myself as an expert in psychiatry or, mental health conditions, but I can speak to the spectrum of experiences that I have seen, especially in our own continuity clinics. And so perinatal health conditions most commonly include these conditions that you see here, inclusive of depression, anxiety, bipolar disorder, postpartum psychosis, as suicidality. Now, this affects 1 in 5 mothers, and it can occur during pregnancy as well as during the first year of the postpartum period. But it's not only inclusive of these conditions listed, but also pre-pregnancy conditions. And so when I am screening my patients or triaging them, especially at their initial OB physical appointments, when we see histories that are inclusive of these conditions or family histories, um, we tend to one record them just so that they have continuity, but also just keep a bit more vigilance and a bit more care because these can especially exacerbate during the pregnancy. Now, there are several short and long-term effects that are described in the literature, and so this becomes really important to identify this really early and initiate treatment whenever appropriate, as early as possible. So when you think about the short-term effects, this includes the impact to mental health load and your daily quality of life, especially in the light of pregnancies that may add stress and stress load to themselves as well as their loved ones, but also long-term effects that includes disengagement with medical care, exacerbation of comorbidities, especially in the cardiovascular realm, substance use disorders, as well as the association with maternal morbidity and mortality. So screening tools do exist, but it's pretty much agreed among professionals that these conditions are ultimately underdiagnosed and undertreated. And so when I think about the patients I see both in labor and delivery and in clinic, those with risk factors are often lost to follow-up. We'll see them sporadically. At the very most, we do monthly visits with our patients who are in the first trimester, but it's not uncommon for me to see patients who have just a visit here and there, maybe even one visit during their entire pregnancy. And so when working with our Promise to Hope program, which is actually our substance use recovery program where we connect them with resources, I often talk to my patients, say that you are dealing with a lot on top of a lot. Pregnancy can add to that load and just make it hard to allow it to connect with the resources that you might need. And so when we talk about the increase in, or rather the worsening of outcomes, both maternally and fetally, this can be associated with increased risk for stillbirth, low birth weight, and decreased maternal bonding, impaired development, and an increased frequency of mental health conditions, which often is quoted in literature as continuation of generational mental health impairment. The very existence of maternal health conditions is really considered to be an adverse child experience, which is known to be associated with just future cardiovascular morbidity, and all-cause mortality. So when we talk about screening, one such tool that we often use in, thinking back when I was a medical student and rotating in hospitals, but also in our own clinic here, we often use the EPDS scale, which stands for the Edinburgh Postnatal Depression Scale. Each of these questions here are scored from 0 to 3. And a score above 13 shows association with presence of a depressive disorder. But then what do you do with a score? I think it's the most important question because screening by itself is really great for identifying a point of opportunity, but placing pathways on or placing patients on a pathway of referral and monitoring and remission are equally, if not more important. And I think this highlights just the difficulties that you can have with siloed care versus integrative approach. I know with our own clinic over at Miami Valley, we've been working on integrating a lot of services within our own L&D clinic. Recently, we've employed a social worker who just shares an office with us. We've employed family medicine and internal medicine who share separate wings of this clinic. And we are working on including dentistry in some point during this clinic. The reason that's important is because our patients don't have to wait for referrals to come in and to schedule different appointments. It's gotten to the point now where, after I see a patient and if I identify them to be at risk, I can simply just walk them to across the hall in the care of another professional, and they can continue their care and allow the patient to feel engaged and in control of their own care. So just a brief recap, and again, this might be useful to our two medical students here, and I'm kind of looking fondly at you just because I was in your position a couple years ago during this elective myself. But in terms of major medical conditions that you might encounter, first one we have here is MDD, major depressive disorder. It's really highlighted by many of these symptoms here. And I'll leave you to read that. But usually, if you have about 5 of these symptoms, especially with having depressed mood or anhedonia, you can kind of rule in for this. A significant memory mnemonic is the SIGI caps, of course, referring to sleep, interest, guilt, energy, concentration, appetite, psychomotor effects, as well as suicidality. Moving on to generalized anxiety disorder, it is characterized by really excessive anxiety and worry about multiple events, and 3 or more associated symptoms of consisting of restlessness, fatigue, difficulty concentrating, irritability, as well as muscle tension and sleep disturbances. This can impact daily activities, especially as it relates to sleep disturbances and insomnia. And it's not, we don't use it in relation to substance use or other comorbidities or other mental disorders. It has to be diagnosed as a separate entity compared to those. Moving along, there's also bipolar 1 disorder and characterized by a manic episode with or without hypomania or a major depressive episode. Mania can be described here as grandiosity, excuse me, decreased need for sleep, pressured speech, flight of ideas, distractibility, an increase of goal-directed activity or goal-adverse agitation, as well as excessive involvement in high-risk activities. You might ask yourself what high-risk activities mean, and this can kind of span the spectrum of buying sprees, sexual indiscretion, or even financial schemes. And that latter one, I've actually surprisingly seen quite often among some of my patients. When we talk about hypomania, that's really significant to mania without significant impact to daily activities or a need for hospitalization. When you present with psychotic features, this automatically escalates your diagnosis from hypomania to mania. And then just backtracking, bipolar 2 itself lacks a manic episode and therefore the presence of hypomania or NDD episode. And postpartum psychosis is kind of something that can occur very acutely or else after some duration of months following delivery. And so this is characterized by hallucinations, whether they be visual, auditory, even tactile, even smell. Anecdotally, one of my mentors did say that during one of her most recent encounters with postpartum psychosis had occurred actually a few hours after delivery, and she was endorsing different smells in her room. You can also have delusions, mania and depression, cycling both between mania and depression, your loss of inhibitions, um, excessive suspicion or paranoia, restlessness, confusion, and behaviors that are contrary to baseline character or values. So, looking at the statistics, when we're looking at the frequency and the incidence, particularly with perinatal depression, this can affect up to 14% of women in totality. And when we look at it across the spectrum of pregnancy, it'll be about 27 in the pre-pregnancy period, about 33% during pregnancy, and then about 40% in the postpartum period. When we're looking at bipolar disorder, this affects about 2 to 8% of the perinatal population and as high as about 18%. When we're looking at postpartum psychosis, it's looking at about 1 to 2 per 1,000 births. And so when we look at risk factors, it tends to be classified among a trifecta among biological, environmental, and psychosocial factors with overlap among all of them, really. This is a long list, but I want to highlight a few factors that are kind of important here and seen in the literature to contribute heavily to adverse outcomes. So, race, psychological interpersonal violence, and sexual interpersonal violence tend to be the strongest correlations to perinatal depression. But other contributors that have been found in literature um, include prior history of anxiety, depression, young age, veteran or military association, decreased partner support, unemployment, incarceration, or known sleep issues. And it's kind of self-perpetuating because the birth experience in itself can contribute to both PTSD and anxiety, especially if these experiences compound on itself as they proceed in future pregnancies. And so a lot of times when I do encounter patients who do not have significant others, who do not have support systems, really it's kind of they're in this vulnerable period that kind of makes them susceptible to experiencing really traumatic experiences that can contribute to poor engagement and less adherence to care. Okay. And so when I've spoken in the past about being able to screen, but also being able to place patients on a path of recovery in light of that screen was very, very important. And so um, prevention is really just the best way to kind of allow our patients to be most successful in their pregnancies and in the face of these disorders. And health equity is a very much an important topic because a lot of meta-analyses can show that racial marginalization as well as socioeconomic status can impact access and quality of care. We do see decrease outcome or increase adverse outcomes, especially to Black, Latina, and transgender populations in the literature. And that has kind of persisted over decades. So there are multiple national and domestic psychiatry network access centers that are available both on a local approach through community-based institutions, but also on an online um, basis as well. And so I'll showcase some of these here. But it really focuses on a multidisciplinary approach. As I mentioned before, that's very important and one that we've been instituting in our own clinic. These programs exist for training. They have also real-time consults. You can have resource and referrals as well as healthcare coordination. The two that I'll kind of highlight here and showcase the website following the slide is the ROSE, and that stands for Reach Out, Stay Strong, and Essentials for Mothers of Newborns. I'll go ahead and visit that website right here. And so it's very much a website that was not designed in the 1990s, looks very, very modern with an easy to use system. It's focused both towards patients, but also towards healthcare providers. And so if you can scroll down here, brief descriptions. And we have training videos, or rather, they have training videos that allow for participants and those wanting to deploy these resources in their own clinics and practices um, with PowerPoint slides as well as treatment plans. Moving along, the other one that I'll kind of explicate here is the Mothers and Babies program. Likewise, this is a national online network, again, providing resources as well as toolkits for healthcare providers in order to kind of allow for patient education concerning risk factors and diagnoses of mental health conditions. These become important, especially if you're running your own community clinics, because having well understood and easy to understand handouts and pamphlets for our patients to read can be really instrumental in guiding their engagement with their own care and kind of re-establishing the foci and their control back into their own realm. And so moving on to pharmacotherapy, which admittedly, as a first year resident last year, I was very, very uncomfortable with, but slowly became more comfortable with. We utilize SSRIs as our first line therapy for perinatal anxiety. Um, it's very much highly effective in treatment and preventing relapse. Um, in terms of SSRIs, I tend to ask my patients what they've been on before or what's worked for family members and kind of take it from there. It is advised to use benzodiazepines sparingly in this case, just because of the pronounced side effects that chronic usage may have. In terms of bipolar disorder, valproate is usually used as a first-line treatment. However, you can substitute with lithium. Um, lamotrigine, quetiapine, or olanzapine during pregnancy. If you're choosing to use lithium, of course, it has slight developmental effects, especially in the first trimester period and second trimester. That being said, you should, it is advised to monitor dosing during pregnancy as well as in the postpartum period and necessity of a second trimester growth ultrasound with perhaps Q4 weeks interval growth ultrasounds can be warranted there. The reason being is because this leads to an increased risk of development of Epstein anomaly, as well as other cardiac abnormalities, as well as hypotonia in the post-birth period, development of goiter, as well as increased risk for preterm birth. Um, this last line was really for when I was presenting this to fellow OBGYNs, in that postpartum psychosis absolutely does not need to fall into the realm of just psychiatry that can be empirically treated by OBGYNs, with our first lines being olanzapine or haloperidol, sometimes combined with lorazepam. We can also utilize benzotropine or diphenhydramine with haloperidol to, again, prevent extrapyramidal symptoms as a result of that. And so with that being said, I hope I didn't run over time, but in summary, mental health conditions are common in both the perinatal and postpartum period, inclusive of all these conditions that we've kind of run through. Screening and identification tools are good for determining individuals for which additional care is needed. And positioning patients within the healthcare infrastructure with easy access to care and resource really potentiates success in terms of their treatment and success in terms of their outcomes for themselves and their baby. And psychopharmacotherapy is definitely within the scope for OBGYNs. Initiating patients on their treatment is very much a first way of getting their foot in the door and escalating them in their care. So with that being said, here are my references, most of them taken from the ACOG practice bulletins that you see here, and I can open it up to questions.